Welcome back to the Asia Ventilation Forum ICU Tips and Tricks podcast. My name is Jeff Palo. I'm an intensivist practicing in the Philippines. And with me is Professor John Laffey. He is a professor of anesthesia and critical care at the University of Galway in Ireland. He is chair of the Irish Critical Care Trials Group and head of the Translational Biology section of the European Society of Intensive Care Medicine. Today, we will be discussing the WEAN SAFE study, which was recently published in Lancet Respiratory Medicine. WEAN SAFE is the first global study across 50 countries to describe the weaning process in detail, and it described the different approaches used by physicians in regard to weaning from mechanical ventilation, and the impact of delayed and failed weaning from ventilation in patients requiring at least 2 days of invasive ventilation. John, welcome to the podcast.
Thank you very much, Jeff, and thank you for the invitation.
So we're very excited to be hearing from our experts who, whenever we invite them. The WEAN SAFE study was a very large study. I would like to ask first, how was this study different from previous studies on weaning?
Yes, thanks, Jeff. So we had previously done, this group of investigators had previously done the LungSafe study. And so we had a large network of intensive care units across the world. So we leveraged that in this study. And we felt that we needed a really big study. There had been national level studies and some regional studies. And then there was the study published by Karen Burns and her colleagues, which was around a similar time frame as our study. But what makes our study different, I think, is the size of the study, right? So, we had 50 countries participating, and we had nearly 500 intensive care units. So it's a look at what's happening in the real world, how we wean patients, across all 5 continents. And I think that's what is different about the study.
So could you run us through what were the key findings that you guys found?
Yes, we recruited a subgroup of all patients undergoing invasive mechanical ventilation into the study. So patients had to have had 2 full calendar days of invasive ventilation. And this is because we wanted to focus on the groups at higher risk for weaning difficulty. And so, we recruited 5,869 patients that fulfill those criteria. And I suppose the headline finding is that, over a third of those patients did not successfully wean from mechanical ventilation. So 35% of patients who were 2 days or more in receipt of invasive ventilation did not come off the ventilator. And that is up to 90 days. So they either died or they were still receiving invasive mechanical ventilation at 90 days. And that's one of the other points about the study is we did have quite a long follow-up. A lot of the other weaning studies would go to day 28. And there are quite a few people still in the weaning process that do successfully wean at that time point. So, but we can say that at 90 days, 35% had not successfully weaned. So that was the major finding. And we then found, of that group that did wean, that about 2/3 had a short wean. So once they started the weaning process, they weaned within 24 hours. So and then about 10% required 2 to 6 days of weaning before they successfully weaned, and 10% had a prolonged wean. So, and then 16% ultimately failed. So they entered the weaning process, but they didn't succeed.
So the 35% that did not have a successful weaning, this included everyone that also died within their ICU stay or within those 90 days of follow-up.
That's right. Clear. Exactly, yes. So 20% of that 35%, 20% did not enter the weaning process. Now, one of the challenges in this study was terminology, right? So, we defined entering the weaning process as an attempt at ventilator separation. And so that could be a spontaneous breathing trial. it could be a direct extubation, and but you had to have an attempt to wean you for sure that you were in the weaning process. And so of those, that 35% that didn't come off the ventilator, 20% of them didn't enter the weaning process, while 15% did but failed.
Okay, that is a big difference between the one outcome and the other.
Yeah.
So within those patients that were successfully weaned, so we are talking about the 65% that were successfully weaned eventually. You were looking at the factors that were promoting or were associated with successful weans. Could you please describe what you had found there?
Yeah, so we looked at all patients who entered the weaning process, whether they were successful or failed, because what we wanted to understand was, were there things about the weaning process that affected success or failure, and that we might be able to modify, right? And so the differences in practice, allowed us to look at this, right? So what we found was that, some people were delayed in weaning, and what we meant by that is when they met general weaning criteria. So they were on relatively low ventilator settings. So a PEEP of 10 or less, an FiO2 of 0.5 or less, not getting a muscle relaxant, not on a higher dose of pressors, that these are people who were potentially ready to wean. So when we saw delays between having those criteria and the start of the weaning process in terms of the start of a separation attempt, we wanted to look at that, right? So what we found was that older, more frail patients, non-trauma neurologic admission. So if they had neurologic conditions, they were at higher risk for delayed weaning. Now, they're not factors you can really modify, right? But what we found was that there were modifiable factors, and the key one was sedation. And so we found that patients who were at higher levels of sedation at the point at which they reached the criteria for weaning, that was independently associated with delays in initiating weaning. And that's important because we found that patients who were delayed in initiating weaning were more likely to fail the weaning process. So that to us appears to be a factor that could be further optimized.
That is quite true. I mean, I know that in a lot of ICUs in Asia, even sedation protocols are not in widespread use. And so something like that may really impact the futures of our patients later on.
Yes. Like one of the interesting points that has come out after the paper was published, and it's something we did think a lot about at the time, was whether or not we should have included sedation as part of our evaluation for readiness for weaning. So there are two schools of thought there. One is that we should, and that level of sedation is something that should be scored as part of the weaning process. However, we made a distinction between readiness for weaning and readiness for extubation. Clearly, you need to be reasonably awake and cooperative to successfully extubate, but that's not necessarily needed to start weaning, right? Sure. So, and the second point was that if we did include it, we wouldn't be able to examine the effect of sedation. And we decided up front that's something we wanted to really look at, was the interaction between sedation, weaning readiness, and weaning success.
Was sedation the only modifiable factor that
in terms of weaning failure, sedation and delays in initiating the weaning process, they were the two major modifiable factors. So, based on our data, we need to pay attention to sedation, and then to really start to wean people as early as possible. So start the weaning process. Start thinking about weaning really as soon as the patients, are through the acute phase of their critical illness.
So when a physician decides that they would not be even checking whether their patient is ready to wean yet, I didn't see this in the paper, but did you have some sense about why a physician would not be doing, or why would they be behaving that way?
Yes, I mean we where patients met our defined weaning criteria, we did ask the study teams at the sites to give us additional information. Now, what's come out of that so far is the sedation, because that was one of the things we asked about at that point. But there are other pieces of information there around fluid balance and things like that that we haven't fully interrogated yet. We suspect that that there may be something there in terms of a role for fluid balance as well. But the one we've seen so far in terms of an explanation is our a sedation level, and then sometimes there were things like that there were other planned procedures, maybe imaging, this kind of thing, where people delayed the wean for another day or two to allow these things to occur.
Right. So I was trying to compare the practices within our own center among physicians, and I find that the variation in practice is just so wide, and you could get 5 different people seeing the same patient, and then have such different stances when it came to their assessment of readiness to wean and their weaning practice itself. So I was very happy to see this study, which described what the rest of the world was doing, because sometimes I really worry that we are doing our patients a disservice by keeping them on the vent for much longer than they need to be.
Yes, like there is a lot of variation, and you're absolutely right, Jep. We saw that variation was right down into the ICUs. There wasn't a strong effect of center, for example. So, and there wasn't a strong effect of geography. So, European ICUs didn't wean faster or slower than North American ICUs, for example. And so where we see the variability is right down at individual practitioner. And one of the other interesting findings was that, having a weaning protocol didn't impact weaning practice in terms of when you started weaning or your success in weaning. And of course, just having a piece of paper isn't going to, right? You have to have, that has to be taken into practice, and people have to be doing it. There is a lot of variability, and again, the terminology is an issue, because one of the things we had to interrogate, we had to go back actually to ICUs afterwards and ask them about whether or not they did spontaneous breathing trials, because we had ICUs that told us they didn't, and then when we looked at their data, it looked a lot like a spontaneous breathing trial, like what I would call a spontaneous breathing trial, but the team would say, no, our ICU doesn't do spontaneous breathing trials. So
right.
we have different, like, so what I call a spontaneous breathing trial and what you call a spontaneous breathing trial, is often quite different.
Right. Okay, then that did make things a lot more complicated in the analysis.
Yeah, some people, don't call it a spontaneous breathing trial unless they're putting patients on a TVs, for example.
Right. I can see where that happens.
Other people, as soon as you go over onto a spontaneous mode and you drop pressure support for a while, I mean, that fulfills the criteria for spontaneous breathing trial in our understanding of it. So there is quite a bit of variability, and one of the things that needs to be done, and this is something that's happening as a separate project, but informed to some extent by this, is a guideline that looks at terminology and looks at practice with an aim to try to standardize these things.
Right. I mean, that's really the next step. Otherwise, we're
talking exactly. We're talking about apples and oranges.
Right.
Yeah.
So I'm just wondering, besides the what had been found regarding the modifiable or the ones that did predict either earlier or later weaning, what were the factors that you found were neutral or had no bearing at all, which some physicians might be thinking as important? Did you find anything like that?
We did. I mean, we found, that age, for example, say for risk factors for weaning delays, and we found that age didn't seem to make a big difference. Being immunocompromised, being obese, these kinds of things didn't make a big difference. And as I said already, a weaning protocol didn't seem to make a difference. Whereas we found things like, if you were planned surgery, you were more likely, to wean on, early and well. But things, as I say, like protocols, like where you're located, they didn't seem to make, they didn't impact on the process.
Yeah, I remember when I was reading it, I was actually surprised that the weaning protocol, whether you had one or not, was actually not a big factor. And then you're right that it's different to have that piece of paper versus really doing it in practice. But I remember there was a lot of excitement about that before, about having a weaning protocol and actually having a non-physician to direct it or something like that.
And that's another, yes, and like we thought that, so we thought there would be a weaning protocol, might show a signal, right? But at the end of the day, it is, it's a piece of paper, and if it's not uptaken into practice, it won't have any effect, right? So, and a study which looks at implementation of a weaning process protocol, and ensures that staff are familiar with it and agree and have had input into the protocol, that's much more likely to be used in practice. And so we can't tell you whether or not, if a protocol, when it's implemented in that way, would make a difference. But in the real world at the moment, when we look at sites that have a protocol versus those that don't, we're not seeing a difference in practice.
So I'm wondering if, it's fair to ask this question. After the lessons that we've learned from WEAN SAFE, what would you say would be the optimal practice for someone who is taking care of a patient on a vent for respiratory failure, not just simple OR issues?
So I think, in the group that are more than a couple of days on the ventilator, once they get through their acute illness, that you need to be looking, you need to move your mindset into the weaning process. And I think sometimes, as critical care physicians, we maybe take our eye off the ball a small bit when it gets to that part of the process, right? So we're very, very engaged in the acute illness situation, in the diagnostic pathway, in instituting therapies and procedures and so forth. And then, when patients transition and their ventilator requirements drop off or their pressor requirements drop off, maybe they're not getting the same attention, right? And so, once they get through that, we need to switch mindsets very quickly and say, okay, we need to optimize this patient. We need to optimize fluid balance. We need to optimize sedation. We need to start the process of weaning as quickly as we can. And you made a point there about differences in who's doing the weaning. So we thought that might emerge, like, so countries that have respiratory therapists, for example, like North America, but we didn't see in our analysis so far, and it is something we do need to dig into a little bit more, but we didn't see an obvious difference in sort of practices.
So does this mean we're going to be expecting a little bit more data later on about
a
little more nitty-gritty?
Yeah, we are going to be issuing a call for new studies. So the way we work in the collaboration is that if you've participated, then your number one, your data is yours, right? You have access then to proposed studies and sub studies, which we will then, as the executive committee of WEAN SAFE, we will look at, assess. We'll often bring teams together because more than one group may have decided on the same study. So, and then we develop, a number of sub-studies that we then will work through. So yes, I mean, you can expect, that there will be subsequent studies from the data set. And so people who are WEAN SAFE investigators, keep an eye on the European Society webpage on WEAN SAFE, because there'll be a call issue there.
So excellent. Hopefully, my country can join this time.
That would be great. That would be great, Jeff. Yeah, yeah.
There was a statement in the key points regarding the strength, and we just needed to like emphasize the importance of it. There is a statement about at 1 year following critical illness, if the patient required invasive ventilation organ support, the duration of ventilation besides older age was one of the strongest predictors of survival and quality of life. Um, did Could you comment more on that?
Yes, I mean the ventilator does decondition the patient. And there's a lot. Obviously, there's a lot going on in terms of the patients who require longer ventilatory support. But the quicker we can get the patients off the ventilator, then the better their chance of getting out of the intensive care unit and back to their activities of daily living and back to a quality of life that it may be closer to their pre-morbid quality of life. And the data for that is not in this study, but it is very strong. That duration of ventilation is a key factor. And when you think about your ICU, I mean, most of your patients, your longer stay patients spend a long time in the weaning process. So it does seem to us that this is an area where, we really do need to attack it and start to really develop, approaches that optimize the weaning process. So this is a first step. We've discovered, I think, quite a bit, about how we practice. And now we need, good guidelines in regard to, what is the best approach, standardization of terminology, and then ultimately we need clinical trials that are going to test some of the ideas that are coming out of this work.
I think this is going to be a challenging time because normally our the therapies that we do in ICU are usually like aggressively started. Now we need to really think about aggressively taking them out all the time, and it's been there. It's been in the textbooks, yes. But we're seeing more and more data, and we just want more physicians to realize it, I guess.
Yes, exactly. And I mean, there is, as you said, I mean, there are studies looking at, sedation breaks, sedation optimization of fluid balance, all of these things. So we have good, direction on how we might optimize these things. They need to be, further tested, but this is an area where we really need to pay attention to the details, and get these patients optimized so that they have the best chance of coming off the ventilator and staying off the ventilator.
So if it's okay, if we could depart a little bit from the study itself to the process of you guys doing this international cohort study. Yes. What are the things that you liked about it, and what are the things that maybe you would have changed about it?
So I mean, what I like about this kind of work is that you get a picture of actual practice and actual outcomes outside the study situation, because trials are of course extremely important in advancing practice and therapy, but they're less good at understanding real world management and outcomes. So these kinds of studies they're important because they give you that picture, and but they are challenging to do. We had the advantage, that we had a group that had done the previous Lancet study, and we were able to bring a lot of that team together again to do it. We were supported by the European Society of Intensive Care Medicine and the European Respiratory Society in terms of sort of practical support for the study, for developing the CRF, and also some financial support. And it was their networks that really helped us in recruiting centers. So that those parts worked well. The challenge, is a lot of it is around data management, the movement of data, across borders. That's becoming and for good reasons, that's becoming increasingly scrutinized, and so there's a very high level of data security required, and that does that means that you have to pay a lot of attention to that. It means that analyses, a lot of them have to be done centrally because the database can't move around. And that's a challenge, right? So and for observational studies like this, you do need a large participation. So some countries have really quite different approaches to other countries. And for example, for some countries, for observational studies require patient consent. And the difficulty with that is you're not then getting the full sample, right? Because you'll have a group, a non-random group that are not included, right? And so that they are challenges, and I think we do need to look at, as a research community, and this is broader than intensive care medicine, but at ways of getting good quality, anonymized data that will help us to understand practice.
I can imagine it must be very exciting and very challenging. You took care, you were talking to 500 different ICUs or 500 different hospitals here.
That's right. Yes, and we did get a lot of help. The European Society of Intensive Care Medicine, Guy Francois, who works there, he's their research director. He fielded a lot of the day-to-day queries for us, and that was very helpful. And then aggregated those, and so we used to have an FAQ, like a frequently asked questions. So if we got a good question, we would put that answer on the website so that people could see it. But it was a very intense interaction, and great. I mean, it's great to have a community of people who do this work, because nobody got paid, right? That there was no funding. There was funding for the infrastructure, but there was no funding for sites for that work. This work was all done by sites on a voluntary basis, and this is why we're keen that the sites now get something from this, as well as understanding global practice, that they have a data set that they can use, and that they can bring groups together and propose studies.
Yeah, well, I'd like to thank your researchers, your co-researchers, co-authors, and all the sites that actually joined. Otherwise, we wouldn't be able to gain the benefit of these huge studies that are now possible.
Yeah, thank you. And I mean, I would like to thank, the members of the executive committee of WEAN SAFE. So that's Tai Pham, Leo Hyunks, Jack Mobilani, and Laurent Brochard, as well as a large steering group. These people all did a huge amount of work. Like, it's a big team effort. And, I'm privileged to be, discussing it here with you today and representing that group.
Yes. Well, before we end then, would you have a final message for our listeners and our viewers?
I would say two things. I think one is that the weaning process is something that we need to pay more attention to, and that there is a very real prospect that we can improve outcomes by standardizing our practice, weaning patients at the earliest opportunity, and paying attention to things like fluid balance and sedation in these patients. The second thing I would say is that these types of studies, it's really critical that we continue to do these types of studies. They are getting more difficult to do for the reasons we discussed, but they really are very important for us to understand the real world practice of critical care medicine.
Thank you, Professor. So this is the end of our podcast edition. Again, this was we were speaking with Professor John Laffey, and this was the Asia Ventilation Forum ICU Tips and Tricks edition. Hope to see you again later on. I guess we are going to be talking more about the next blank safe, because it used to be lung safe, now it's wean safe. There are probably other safe studies later on coming out. So
that's right. We hope to keep going. Exactly. Yeah. And thank you very much. I really appreciate the opportunity to discuss with you and your colleagues in the Asia Ventilation Forum.
Thank you very much for accepting the invitation.